Welcome to Voices in Action, a new podcast by the Eastern Oregon Center for Independent Living about disability in Oregon. I'm your host, Leo Alenak. Over the course of this first season, we'll cover a variety of topics related to disability justice education, speak with leaders of local advocacy organizations, and learn from one another in the process. This week, we'll be discussing HIV services in Eastern Oregon. While those outside of the state often assume Portland's record of hipster liberalism is a widespread cultural affair, outside of major blue cities, and especially in rural areas, Oregon is extremely conservative. So for something still as highly stigmatized as HIV, it can be incredibly difficult to access knowledge and healthcare services. An article by Wear Your Voice magazine explains what you should know about HIV/AIDS prevention and treatment. Quote, "When people think of HIV and AIDS, they think all sorts of things including death and exposure. They think of myths that have been around since the 1980s that continue to persist today. It's our duty as people who love and support those with HIV/AIDS to pick up the slack and challenge these myths because they are damaging to people living with HIV/AIDS, and they're detrimental to preventing the transmission of HIV/AIDS. You can't catch AIDS. You can only get HIV. AIDS is a condition caused by HIV when the virus has destroyed much of the immune system. Many people living with HIV never actually progress to AIDS and can live long, healthy lives with healthy immune systems if they adhere to treatment. If a person living with HIV's immune system gets too low, they're diagnosed with AIDS and that diagnosis stays with them, even if their immune system gets back to normal. You virtually cannot get HIV from a person if their treatment has made their HIV levels undetectable. They do not have free copies of the virus floating around, so you can't get it. According to the U=U consensus statement, the risk of transmission of HIV from a person who has the disease who is on medication and has an undetectable viral load is non-existent. Even someone with a detectable viral load can't pass on the virus 100% of the time. It's actually very hard to pass it on with sexual means. Now that we've talked a little bit about the facts behind HIV, it's time that we talk about the facts about PEP and PrEP. PrEP stands for pre-exposure prophylaxis. It's a medication used to prevent the spread of HIV in people who have a high risk for being exposed to the disease. PEP stands for post-exposure prophylaxis and is used to prevent infection by HIV in people who've already been exposed to the virus. PrEP can only be prescribed by a doctor or nurse practitioner. Talking to the doctor about sexuality can be difficult, but you can also research online to find a provider who's able to prescribe it to you. Queer competent doctors are most likely to understand why you might need PrEP. PrEP is covered by most Medicaid providers and some private insurance companies too. Although it may be hard, you can get on PrEP." End quote. In this episode, I spoke with Jeff Williams, the Director of Housing Services for EOSIL, and Kelly Rumsey, the Director of the Ryan White HIV Case Management Services for EOSIL.
My name is Kelly Rumsey, and I am the Director of Ryan White HIV Community Case Management Services for Eastern Oregon Center for Independent Living.
Hi, Leo. My name is Jeff Williams. I'm the Director of Housing Services for Eastern Oregon Center for Independent Living.
Great. So what is the Ryan White Community Case Management Program?
So the Ryan White HIV Community Service Program is people living with HIV who are eligible to enroll in care coordination with our agency, Eastern Oregon Center for Independent Living, or EOCIL. It's a national award-winning program recognized for best practices in providing an array of quality of services to individuals living with HIV. The program also is offered from a philosophy of client control, peer models, and self-advocacy. EOCIL's HIV Community Services implements Oregon End HIV strategies, which are getting tested, prevention, and treatment. EOCIL's HIV Community Services also is comprised of 4 programs, the Ryan White HIV Case Management Services, the Cultivate Housing Program, Health Insurance Enrollment Assister Services, and the Harm Reduction Services.
So then both the Ryan White program and the Cultivated Housing program are under a larger umbrella then, correct?
Correct.
Gotcha. Okay. So can you tell us a little bit more about the Cultivated Housing program?
So the Cultivate Housing Program, it's a comprehensive and intensive trauma-informed approach to providing core treatment and sustainably services to eligible individuals living with HIV. So I have noticed a lot of our clients have had a lot of trauma in their life. So we look at people that everyone has had a trauma in their life. And so we approach these services in that way. The Cultivate Housing program also follows the End HIV Oregon initiative, which focuses on eliminating new HIV infections through testing, prevention, and treatment, like I mentioned before. It's also designed to assist individuals experiencing behavioral health and addiction challenges. So this program was mainly designed around mental health and addiction. A lot of people that are having behavioral health or addiction challenges have a hard time retaining or maintaining a household, applying for housing if they don't have good credit rating or they don't have good rental history. The Cultivate Housing program aims to increase low barrier supportive housing options for individuals living with HIV in rural Oregon. So we want to take away those barriers that they may have, like transportation in Eastern Oregon. Transportation's a big deal. We do have here in Pendleton, Umatilla County, a free busing system, but we cover 12 counties in Eastern Oregon. So not all counties are like Umatilla County, as well as assist with financial assistance and ongoing intensive case management. So we provide rent assistance, rent deposits, pet deposits. We can buy household items for them if they've been homeless, and then we get them into housing. If they don't have anything to go into that unit, then we can buy that for them. We can also do utility assistance. So in utilizing these services as support factors in achieving and maintaining medical and psychosocial stability, the core components of the Cultivate Housing program are intensive in-home behavioral health supportive services. So we like to go where they're at. A lot of individuals don't like an office setting or are uncomfortable in an office setting. So we go to the person and provide the case management services, which these services are intensive case management services. So unlike the Ryan White program, we're able to provide more intensive case management services. So skills building to if they need to learn how to clean their house. Some people don't know how to clean their house properly, how to maintain a good relationship with the landlord and so forth. The program will prioritize those with the most significant housing barriers, including but not limited to mental health, substance abuse, and criminal history. So mental health and substance use, if somebody's in and out of jail or in and out of prison, it's really, really hard to be able to rent an apartment or a house. The long-term goal is to bridge individuals living with HIV with the necessary mental behavioral health treatment options and prepare them for permanent, supportive, or independent housing programs. So this is like a transitional housing type setting. So the minimum in this program is about probably 2 years, depending on the person. Some people progress in the program more faster than the others do. So the minimum is 2 years, the maximum is 5 years in this program. So while they're in this program, we pay the rent. They have to pay a portion if they have an income, which is teaching them responsibility to pay the rent on time. We have a due date that they have to pay that. And then we also, another goal is to assist individuals living with HIV to access effective treatment and maintain undetectable levels of the virus, HIV virus. So we want, if they're detectable virally, we want to bring them down to undetectable levels and keep them there.
Because you mentioned that the housing program does outreach with previously incarcerated people, which is to your point, super important. I was wondering if the HIV case management program also does outreach with some of the most marginalized demographics and those most at risk, for example, incarcerated folks and sex workers.
Yeah, I know because I used to work in the Ryan White program before I took over in the Cultivate Housing. And we also do the same in the Cultivate is we work with prisons, jails. So if somebody's getting close to getting released and they have HIV or disability, then we work closely with that release counselor, probably within 180 days of release. So we can do a warm handoff to us and transition them into housing and get them what they need.
The nice thing about the outreach with the Cultivated Housing Program and the Ryan White HIV Community Services Program is we do similar outreach to all the same, like the correction facilities, medical providers, different things like that. So if Jeff's out presenting and doing outreach, he can also share about my program, and then I can also do the same and share about cultivated housing.
So are these programs then unique to Eastern Oregon? Did they start with EOSIL or are they part of a larger national structure?
So they are part of a larger national structure. Each state provides similar types of services in their own state. But what makes EOCIL's HIV community services unique is that they are located within a center for independent living, and they are delivered using the IL philosophy, which is the independent living philosophy of client control, peer models, and self-advocacy. So one of the important things Jeff mentioned earlier that in cultivated housing, it's a lot more intense and structured like care coordination programs. And with the Ryan White program, we're more about the client driven. We don't do so much of the hand holding, I guess you could say. We do a lot more of, like I said, just the peer models and the self-advocacy stuff. But traditionally, HIV community services are provided by a local public health authority, like your local health departments or other agencies using the medical model philosophy.
How do these programs, we've kind of talked about how they relate to each other, but how do they relate to disability and disability advocacy as a whole?
With people with HIV, we also are looking at stigma on top of the other things that may be going on in their life. So there's been instances where the landlord has found out that they were HIV and either didn't want to rent to them or didn't feel comfortable renting to them. So we step in and advocate on behalf of the client. We also work closely with Oregon Housing Authority as far as fair housing, Oregon Fair Housing. So we're really versed on client rights and tenant rights and landlord rights. So when there's an instance where there is discrimination, we act on it immediately.
You know, our programs, especially with the IL philosophy, our programs are for everyone. So, of course, for my program and Jeff's program, the individual would, of course, need to be HIV positive. But we also are there to kind of advocate for those individuals who aren't represented in the medical field and feel that they need some assistance navigating through that system. It can be scary. Like Jeff said, the stigma alone is scary and can make people afraid. And then someone who's newly diagnosed, might not know where to go for services or what's available to them. So I think at EOCIL, we take great pride in really helping those individuals navigate the system, get them into proper services, and just being there as a support and, maybe even a friend in some cases.
So what is the biggest obstacle in helping community members access these services?
So we both have used the word stigma. Especially in these smaller rural areas in Eastern Oregon. HIV is not as common or not as commonly talked about it as it is in bigger, more populated areas. So stigma is a huge, huge issue and a huge fear. And then there's also just the lack of knowledge, I believe, that communities have and being able to relate to community of color. So the lack of community knowledge about HIV and the needle exchange program, being able to relate to communities of color, and struggles with getting the word out about all of Eastern Oregon Center for Independent Living Services. And these are all things that we have barriers to that we're really working hard to knocking those down.
And I would like to add on that question is in the Cultivate Housing program, the biggest obstacle I think I have in this program is client buy-in and participation. You don't have to be clean to be in this program, but you have to work towards it. So individuals have a hard time understanding that, sooner or later, they're going to have to address their addiction or mental health issues. And some don't believe they're issues. So I think that's the biggest obstacle. And then the lack of HIV physicians in this area. Most of our clients have to go out of town to see a physician. So we provide transportation for that. But, somebody that doesn't have a car, that's a huge weight on their shoulders is, how am I going to get to my appointments? I got to get my labs. I got to get my medications. So we try to take away that weight on their shoulders and put a little bit on ourselves and take them to doctor's appointments and be able to pick up their meds, take them grocery shopping, etc.
An article published in 2011 by thebodypro.com titled Disability and HIV, Eliminating Barriers to Sexual Healthcare and Education, expands on how HIV is deeply interwoven with disability. Quote, worldwide, HIV/AIDS prevalence among people with physical, sensory, or intellectual disabilities equals or exceeds general population prevalence. In the United States, people living with disabilities face a greater risk of HIV infection than the population at large. Addressing HIV/AIDS among people with disabilities starts with recognizing that many people are sexual, regardless of whether they are living with disabilities. The next step is confronting stigma and misconceptions. Chief among the many misconceptions that individuals living with disabilities may face are perceptions that they are not sexually active, are asexual or sexually abnormal, do not have the same physical and emotional needs and desires as non-disabled individuals, and are incapable of understanding sexuality. These beliefs, while reflective of the larger fallacy of ableism, pervasive in many corners of our society, often lead to negative health outcomes because they prevent individuals living with disabilities from accessing essential health services, particularly sexual health services. Misconceptions and stigma can be particularly harmful when they interfere with access to sexuality education and clinical services. Providing sexuality education, particularly for youth, is essential to lowering HIV transmission and prevalence rates among individuals living with disabilities, but it is also a major challenge. Young people living with disabilities often miss out on sexuality education offered to their non-disabled peers because they are enrolled in separate classes at mainstream schools, attend special institutionalizations that do not include sexuality education in their curricula, or do not attend school at all. Children living with disabilities account for 1/3 of the approximately 72 million children worldwide who do not attend school. In addition, community sexual health education campaigns often fail to reach individuals living with disabilities because they do not present information in accessible media formats or venues. For example, people with visual or hearing impairments may miss out on posters, pamphlets, visual demonstrations, television campaigns, billboards, and radio programs transmitting sexuality education information. Lack of access to appropriate information elevates the risk of infection for HIV and other sexually transmitted infections. In clinical settings, physical, sensory, and intellectual disabilities often compromise standards of care by inhibiting confidentiality and degrading the patient-provider relationship. Individuals living with disabilities may have to bring family members with them to communicate requests for HIV tests or other healthcare services, may be unable to access the physical space of clinics, or may face bias on the part of providers, deterring them from seeking care. For many people living with physical disabilities, lack of access to sexual healthcare services is the greatest impediment to protecting themselves against HIV and other sexually transmitted infections. Transportation to and from healthcare providers can present significant obstacles. Public transportation is often inaccessible to those who use wheelchairs or have limited mobility, and disability parking, ramps, elevators, and wheelchair-accommodating doors are not always available. Relying on family members or friends for transportation can inhibit attendance at healthcare appointments or even deter people with disabilities from seeking sexual healthcare services in the first place, out of concern that medical confidentiality will be compromised. Many healthcare centers do not have equipment, such as examination tables and scales, modified for people who use wheelchairs. One study of physicians' offices found that only 39% of gynecological healthcare providers had used or purchased an adjustable exam table, and only 2% had a wheelchair scale. These types of deficiencies can lead to incomplete examinations. Another study found that women with high levels of physical disability were 57% less likely to report receiving pap smears, and 56% less likely to report receiving mammograms than non-disabled women. Women with physical disabilities often feel that healthcare providers lack sensitivity and knowledge about their disabilities, and doctors do not often talk about contraceptives or sexually transmitted infections because they believe their patients living with disabilities are not sexually active. Not surprisingly, this has led many women with physical disabilities to avoid regular gynecologic visits, a step backward in the fight against HIV. Research discerning current HIV/AIDS prevalence rates among people with various types of sensory impairments is lacking. However, one recent study revealed that HIV prevalence among the deaf population is nearly twice as high as that among the hearing population in Maryland. For people with sensory impairments, particularly hearing impairments, communication is the primary barrier to healthcare access. People with hearing impairments may use American Sign Language, ASL, as their primary mode of communication and learn English as a second language. Because ASL is not based on English and has very different grammar and syntax, many ASL users have lower English literacy than the general population. This makes written health informational materials, typically written at a reading level that surpasses that of the average ASL user and constructed with few illustrations, difficult to comprehend and minimally useful. Healthcare providers may believe that lip reading and note writing are adequate ways of communicating with patients with hearing impairments, but both of these techniques have significant drawbacks. Similar to comprehending written health informational materials, both lip reading and note writing require a high level of English literacy, especially when healthcare professionals use technical medical terminology. Some people with hearing impairments may not be physically able to write due to an illness or other disability, and accents, mumbling, fast speech, facial hair, and medical masks may complicate lip reading. Interpreters are not always available, in part because healthcare professionals do not understand or fulfill their responsibility to ensure effective communication by finding and hiring interpreters. Conversely, when interpreters are present or family members or friends are brought to appointments to facilitate communication, some patients with hearing impairments feel that their confidentiality is compromised, inducing situations where medical error may result from inaccurate or incomplete information. For people with visual impairments, many common forms of sexual health information such as videos, pamphlets, and visual demonstrations are inaccessible. Healthcare providers infrequently provide materials in other formats such as large print, braille illustrations, and audio tapes. Some people with visual impairments report difficulty filling out forms, navigating clinics, and receiving written communications such as test results, prescriptions, or medicine labels, and feel that healthcare staff are not fully aware of their needs. One educational priority for people with visual impairments is correct condom use, which is often demonstrated visually rather than explained orally or interactively. A failure to communicate this type of important information completely and accurately puts people with visual impairments at risk for HIV and other sexually transmitted infections. The lack of adequate sexual health education for people with intellectual disabilities is reflected in the research about their knowledge of HIV/AIDS. In one study, young adults with mild or moderate intellectual disabilities demonstrated significant gaps in knowledge about HIV/AIDS and risk reduction methods as compared to a control group of non-intellectually disabled students. They also exhibited maladaptive attitudes regarding HIV risk in condom use, and when presented with hypothetical risk situations, they were more likely than non-intellectually disabled peers to present unsafe sexual solutions. Intellectual disabilities also put individuals at risk for HIV infection because they increase vulnerability to sexual abuse. In many cases, the criminality, culpability, and moral repugnance of such abuse are clear. In other cases, sexual abuse is more difficult to prevent and detect because of the challenge of discerning ability to consent to sexual activity and the confluence of victim and perpetrator roles. The United States Department of Justice reported that 68% to 83% of women with developmental disabilities experience sexual assault during their lifetimes. The effects of sexual abuse of people who are living with intellectual disabilities may be compounded by hurdles to obtaining police intervention, legal protection, or prophylactic care, communication or access hurdles that non-disabled individuals do not face. Data on HIV/AIDS prevalence among people with serious mental illness continues to evolve. In 2001, a multi-site study in the U.S. found HIV prevalence among people living with serious mental illness to be 5% in metropolitan areas and 1.7% in non-metropolitan areas. Another recent study that utilized Medicaid claims found that almost 2% of beneficiaries diagnosed with schizophrenia in 8 metropolitan areas had also been diagnosed with HIV/AIDS, though there was wide geographic variation in prevalence. One of the factors that may elevate risk of HIV infection among people living with serious mental illness is substance abuse, as approximately 34.5% of people living with serious mental illness engage in at least one type of substance abuse. However, research has demonstrated that sexual health education for people with severe mental illness can be effective, confirming that provision of accurate information about HIV and sexuality is critical to the health of people with mental illness. While the problems outlined are numerous and complex, none are beyond remedy. Implementing change to lower risk of HIV infection and expand access to HIV/AIDS care and treatment services for people living with disabilities begins at the individual level. Recognition of sexuality as a human constant, regardless of disability, is imperative. Training and education for healthcare providers on physical, sensory, and intellectual disability issues is also critical. This may encompass expanding providers' knowledge of how to adapt communication for maximally productive interaction with people who are living with disabilities, and educating providers about additional community healthcare resources that are available for people who are living with disabilities. Changes in healthcare provision must incorporate the desires of patients. The first step for providers may be to ask patients living with physical, sensory, or intellectual disabilities how they can be better served. Outside of the clinical setting, additional resources and greater support services are needed for health educators. While many health educators who work with people who are living with disabilities, particularly intellectual disabilities, want to facilitate sexual empowerment, they also struggle to balance limitations that result from inability to consent and vulnerability to sexual abuse. It is important to keep in mind that the challenges individuals with physical, sensory, or intellectual impairments face in accessing HIV/AIDS prevention and treatment resources will vary, depending on the social, cultural, and economic environment in which they live. Nevertheless, as we have discussed, there are primary barriers that are consistent across environments." End quote.
Yeah, and Kelly, you mentioned the needle exchange program. Could you expand on what that is?
I'll actually let Jeff expand on that because he's kind of head first into that program.
So we wanted to do this for a long time. This has been a long time in coming. So our harm reduction syringe exchange program, it's not a traditional one. So we vend all syringe exchange equipment out of a vending machine. So we adopted this out of Las Vegas, started it. They were the first to do it in the United States. And so I got a hold of Track B over in Las Vegas, did a little Q&A with them, and we decided to try this in Eastern Oregon to see if it was going to go or not. And so far, we've been probably 3 months into it. So it's starting to catch on. We're having a hard time building that trust with people that use drugs. So it's just going to take some time to get that trust built. We also provide culturally and linguistically appropriate and non-judgmental education surrounding syringe use, safer injection use, and services, advocacy, prevention, and referral to other community support services. So we look at the person as like Kelly said before, as a whole. Everybody's different. Not everybody has the same needs. So we look at that person and ascertain what needs that they are needing, and then we refer out to other community programs. We also provide clean injection equipment, which reduces spread of infectious disease like HIV or Hep C, which are two of the most common in injection use. There's not a limit of needles we give out. We'll give out as many as they need because we want them to use a clean needle every time they use. And then we improved our harm reduction services that reduces morbidity associated with injection use. Most individuals with HIV also have Hep C if they use drugs or inject drugs. We also offer, like I said before, we vend out of a vending machine. They come in, they get a unique ID number. We don't track names or anything. We give them that unique ID number, and then they can vend out what they need out of that machine. We set the machine so they can use it twice a week. And then when they come back again the following week, then they go through the intake process all over again. And then we also distribute Narcan. So Narcan prevents overdose and opioid use. And then we also have pre-exposure prophylaxis or PrEP, peer counseling, assistance with obtaining PrEP or PEP, and prescriber referrals. We also have HIV rapid home test kits. They can either test here at the office or they can take it home and test at home. All that we ask is that they let us know what the result is. If we do have a HIV positive, then we have steps that we can let them know to take down the road. And then we also do HIV and Hep C testing referrals. We don't do testing by blood here. So we refer out to the local public health department. And that's pretty much what the syringe exchange program in a nutshell is.
Yeah, that sounds really great. So what do you wish more people knew about these programs?
I would just like to share, within our program, we also have an insurance assister program where once individuals are enrolled in the program, whether it be the Ryan White program or the cultivated housing, we have trained staff that are available to assist those individuals in getting signed up for insurance, either through the marketplace, which is like a qualified health plan, or getting them on Oregon's Medicaid program, Medicare Part A, B, and D. So we basically can assist them and guide them in getting enrolled in any type of insurance that they're needing. And then we kind of follow through the whole process to make sure everything's completed. And then at that point, we can also refer to medical providers and different things in the area. But a lot of what we see is a lot of individuals come in and they don't have insurance at all, or they don't have a good insurance, or they've lost their current insurance. So I think that's really important. And another thing that we do too is we don't turn away anyone who's undocumented, so who's not a natural citizen in the United States. We still enroll them and provide them with as many services as we're able to within our programs.
Yeah, that was very well said, Kelly. And, I just want to state also that we are non-judgmental. We don't judge. We don't care what you've been through. We don't care that, you use drugs or you use alcohol. We treat everybody the same. So I just want to be able to reduce the stigma of those situations to where people are comfortable and not thinking that we're going to think lesser of them because they are at risk or doing risky behaviors.
So what is next for these programs? Is there anything in development that you would like to share with listeners?
So in the Cultivate Housing program, we're in the development of purchasing a fiveplex. So we've been running into a lot of difficulty working with property management companies. They just have ridiculous rules. And if you don't have good rental history or good credit, they jack up the price on the deposit. So we're going to bypass that. And we've got a property already selected. We're just waiting for the funding to come through. But we'd like to, purchase a unit here in Umatilla County and then probably in Malheur County next.
Some of the other things that we have to do in Oregon, especially in our 13 county service areas that we provide services to, is we have to get people enrolled in care. There's currently about 219 individuals living with HIV, and out of that number, there's 88 who are actively enrolled in case management services. So we really need to turn our focus into getting out there, doing better at outreach, getting those individuals, if they want to be, getting them enrolled into services and getting them set up with the medical provider so they can live a better, healthier life. And we're really working on strengthening our outreach to the communities of color with the main focus on the Latinx community, as those are big communities in our smaller community areas.
Great. Yeah, that rolls nicely into my next question, which is how can people access these services?
So through all the outreach that we do, it's very, very simple. They can just make a phone call to myself or Jeff, and we can provide our phone numbers at the end of this. They can reach out using our website, which is eocil.org, and it lists all the services about the Ryan White HIV Community Services, as well as the cultivated housing, along with a lot of the independent living program services that are provided. So the website is a great resource of information, but basically just reaching out. Like Jeff said before, we like to meet the person where they're at. So we would set up an intake and ask a few questions. We're very casual. Jeff, correct me if I'm wrong, but we kind of like to look at it. You're just sitting down with a friend and we're asking questions and filling out paperwork.
Yeah,
and then we get them enrolled, and we make referrals where needed to other community services and community partners. And then we get them established with the medical provider and housing or employment services. Some people, like Jeff said earlier, everybody's different. Some people come in and they have a lot of needs and a lot of supports, and others come in and they might just need a referral to a new doctor. So we'll help with the littlest things and we'll help with the biggest of things. It's just as simple as making a phone call or reaching out via email or coming right up to our door.
Yeah, I also wanted to add that, I don't know if we've ever talked about this in the past, but we also have four offices. So we have an office in the Dalles here in Pendleton, Oregon, one in Malheur, Ontario, and then the other one in Burns, Oregon.
A few of EOSIL's clients shared their success stories with me in writing. They have been slightly edited for clarity's sake. Quote, "My name is John Lancaster, and I have been a client at the Eastern Oregon Center for Independent Living for many years now. Everybody there has been awesome. The ones I've known the longest, Jeff and Alexa, have done quite a lot for me there over the years. And I've got to do a shout out to Ashley Jones. Since she's been there, she has been dynamite. She's helped a lot, and she pushed for me to have my rental agreement renewed. She went to the limits on that, but I'd say everybody there at EOSIL in Pendleton, Oregon are a great bunch of people, and out of 5 stars, I give them 10. And I thank God that I am with them. They are a really good family to me. I don't know what I would do without them or where I'd be. Thank you guys." End quote. Quote, "My name is David Turner, and I am thankful to be in the housing program. I like the weekly meetings with my case manager, Nestor. I also like the weekly calls from my counselor, Ben. It helps me keep focused on positive things going on with me. Thanks, David." End quote. Quote, "Nestor, I wanted to take a moment to thank you for all of your support and encouragement through my trying and personal difficulties. Working with you in the Cultivated Housing Program has been incredibly invaluable to me, ending a 4-year period and cycle of homelessness, starvation, personal hygiene, and mental health well-being. Please share with the housing program and your supervisor that I want to extend my compliments to you and the program, making this year to date the best year I have had in a great many. Thank you again for your continued support, Josiah Charles Tuttle." End quote. Quote, "Hi, my name is Robbie Lester, and I would like to tell you a little bit about myself. I am 54 years old. I've been in Pendleton for about 16 years. I've been a part of the EOSIL family for about 17 years. I was going to Ontario from La Grande and working with Kelly. He was a wonderful person to be with and has helped me so much. Working with the team at EOSIL, they helped me with my healthy food program, my Social Security, and the new rent program that assists with lowering my rent. I have been through some rough times. It's hard to believe that I have survived and am now thriving. I am a big fan of Jeffrey Williams, Ashley Jones, Lois, and now Chrissy. I'm just so grateful I can't even put it into words. There's just a lot of love. I truly feel, I know, that they love and care about me. As soon as I walk through the door, I am greeted with so much love and compassion. Not only do I get amazing attention at the office, but the care comes to my home. I've had HIV since I was 18 and I'm 54 now. Jeffrey took over as the office director when Heidi passed away. Heidi was the first person I worked with at EOSIL, and she was wonderful. I started volunteering today with the Harm Reduction Program / Needle Exchange Program, and I absolutely loved it. Here's a little bit of my story. I was homeless, addicted to drugs and alcohol. I was suffering, and I tried to kill myself on February 27th of this year. I took a bunch of pills on a blackout drunk and spent 14 days on a respirator. Doctors didn't think I was going to live. I spent 4 days in the psychiatric ward because I was suicidal. I started going to AA meetings and they saved my life. I'm now 6 months sober. I can't be prouder of that because I never thought I'd do anything consistently but drink. I'm just amazed at the people at EOSIL and how much they do for the community. I can't say enough about EOSIL. I'm thanking God. It just totally freed me. I feel ready to participate in the community and enjoy my life. Staying clean and sober is a big part of it. I can't forget about Ben. Ben is a wonderful counselor. I've met him in person at the Pendleton office. We talked on the phone every Tuesday for an hour, as Ben and I are creating a new action plan on Friday because of my progress. I have exceeded goals on my previous action plan, and I am proud of myself. I have come so far. I'm happy, enjoying another day here, living, breathing, loving, sharing. God, I couldn't ask for more. I haven't worked since I was probably 30, and it's just absolutely a blessing. My heart opened a little more today, just meeting people and being able to help. Volunteering gives me another reason to get out of bed in the morning. For 4 years, I would stay at home in bed looking at the ceiling. I was so mean-spirited, unhappy, just horrible. Now I know there's so much to live for, so much happiness, I don't ever want to be that person again. I'd like to get an LGBTQ meeting started. Somewhere people can go to be themselves and have a safe space. Eventually, I would like to become a drug and alcohol counselor. I am projecting nothing but uphill from here on out. I hope to shine my light on someone and influence them to take a leap of faith." End quote.
I know Jeff and I both mentioned it, but we really are, in all of our office locations, very laid back, very casual. We do things in a professional manner, but we don't do it in a form of, you're not going to walk into one of our offices and feel like you're in a medical office or, feel like you can't just sit and relax. So we really do try to be very inviting. We really do focus on making sure that everything is safe and confidential and making them feel safe and knowing that their information is confidential. We just really take pride in helping people, everybody, including myself. There's times where they just need a hand out and a hand up, and that's what we're there for. So we really don't turn anyone away, and we'll do everything we can to help and assist.
Yeah, I also wanted to add, we also do PrEP services. So it's pre-exposure prophylaxis. So we offer peer counseling and assistance in obtaining PrEP. We also do PrEP prescriber referrals to individuals at risk of HIV. So the PrEP medication has allowed those at risk of HIV to take back control of their life and not let HIV be a center front of not having a relationship or, if you're contracting the virus. If you're at risk of HIV exposure through sex or injection drug use, this is a perfect opportunity to get on PrEP.
I'd also like to say, Jeff mentioned earlier about the HIV home testing kits that we have. Within those kits, of course, you get the HIV home testing kit, which has simple, easy to follow directions on how to administer the test at home. We're also providing lists of referrals and information about our programs, as well as medical providers, different things in the area. But the nice thing about the kits is if you do test positive, then we're there to help you and get you enrolled in services if you choose to be. And then if you're negative, we can also, like Jeff just mentioned, make referrals to local providers in our areas that prescribe PrEP. We can share information about PrEP. Being a part of the gay community in my area, it's shocking to me how many of my friends didn't know what PrEP was or that it was available or how to get it until we sat down and had a little heart-to-heart. So I just think it's important to get that information out there the best we can.
Wow, that's really surprising. I kind of assume everybody knows about PrEP at this point, especially because I see things for it on YouTube all the time.
It was shocking to me too. That's why we had to sit down heart to heart.
Yeah.
I think or like Oregon Health Authority, they're doing a better job as far as putting, commercials on TV about it more. I see, a lot of commercials on TV for PrEP. So I think we need to do a little bit better as far as getting it out there. If you're not on the TV all the time or whatever, you're not going to know about it.
Well, it's definitely different than other medications or things like that, because to your point, you have to battle the stigma and also the lack of information. So it's like, got to have a multi-tiered approach. It's not as simple as like, oh, did you know that there's this new medication for this thing that some people have? There's so many layers of history there as well. So,
well, and also there's misconceptions of PrEP. If they don't take it properly, it's not going to work. So a lot of people are like, oh, when I have sex, I'll take a pill. Well, no, you have to take it every day.
Yeah.
Or it's not going to work.
Can we just state our names and our contact numbers?
Go for it.
I'm Kelly Rumsey, and I'm based out of Ontario, Oregon. And my phone number is 541-889-3119, and I'm at extension 104. Or I can be reached via email, and that's just Kelly, which is Kelly, @eocil.org.
Yeah, and this is Jeff Williams, working out of the Pendleton office in Umatilla County. My phone number is 541-276-1037, extension 201. And then my email is Jeff, Jeff, @eocil.org.
If you're interested in learning more about intersectional healthcare justice, this episode's recommended book is Bodies and Barriers: Queer Activists on Health, edited by Adrian Shanker. The link to purchase this book can be found in the episode description, or check it out and support your local library. Thanks again to Jeff Williams and Kelly Rumsey for speaking with me, and to Robbie Lester, John Lancaster, David Turner, and Josiah Charles Tuttle for contributing their stories. This has been Voices in Action, a podcast brought to you by EOCIL. Stay informed, stay safe, and remember, housing and healthcare are a human right.